Today, I'll be presenting the case of a 30-year-old male, Mr. XYZ. He resides in Hassan, is educated up to class 10, and is a farmer by occupation. Belongs to class 4 of modified PG Prasad classification. He was admitted on 21st December 2020 and examined on 23rd of December 2020. Chief complaints include distension of abdomen since 1 month, vomiting since 1 week, and yellowish discoloration of skin and eyes since 1 week. History of presenting illness. Patient was apparently alright 1 month ago. Then he developed distension of abdomen, which was insidious in onset, gradually progressive, painless, and was generalized. There were no aggravating or relieving factors, no history of pain abdomen, no history of swelling of lower limbs, facial puffiness or aguria, no history of difficulty in breathing, orthopnea, or PAD. Patient also complains of vomiting, 1 episode per day since 1 week. It was yellowish in color, approximately 100 ml in quantity, non-blood stained, non-bilious, and not smelling. No history of blood in stools. Patient also gives history of yellowish discoloration of skin and eyes since 1 week, occur in onset, gradually progressive, first noticed in the eyes by the patient's attenders. History of high colored urine since 1 week. No history of generalized itching or clay-colored stools. He also has history of decreased appetite since 2 months. No history of unintentional weight loss or EV fatiguability. No history of fever. No history of altered sleep-wake pattern or daytime drowsiness. No history of hematochesia, blood in stools, or melee.
I think we'll discuss the presenting complaints. So this patient has come with abdominal distension, you said, for 1 month.
Yes.
So what do you think is the cause for the abdominal distension?
So the abdominal distension could be due to fluid in the abdomen, or it could be due to feces, or flatus.
Okay. So it could be fluid, as you said, feces or a flatus. It could be a fatal neoplasm. So what do you think in this patient the abdominal distension is due to?
So probably fluid, because it is.
So based on your history, can you tell how did you say that it could be due to fluid based on the history?
So it was gradually.
Okay, it was gradual in onset.
Yes.
That could be due to the organ enlargement also. So based on history, how do you say that this distension is possibly fluid? What are the clues on history which could tell you that this is fluid in the abdomen?
Not sure.
If it's fluid, where will the fluid accumulate first?
It will be central in the beginning.
No, it won't be central, no? Which is the dependent part of the abdomen. When a patient lies down, when a patient is lying down, it's going to be in the flanks, isn't it? So the distension would predominantly start in the flanks and then go up possibly. More importantly, if the distension changes with position. Remember, all the other causes of distension do not change with position. If the patient says that when he sits up, the distension is different. When he lies down, the distension is different. When he lies down, the flanks get full. If the patient gives you that history, definitely we are dealing with ascites as the cause. The other very important thing on history you should say about is what has been done to that distension. Once he's been admitted, what would have been done?
Diuretics.
Yeah, diuretics would have been given, but to find out the cause.
Paracentesis.
Yeah, they would have undergone a paracentesis. So that history you should get in your history of presenting complaints. You're going to say that this distension has been there and it has progressed. It changes with position, and after admission, the patient underwent a diagnostic paracentesis. So that would definitely tell you this is fluid, okay? Because For the negative histories for the rest of it, if it is flatus or feces, what are the other histories they would have had?
Constipation.
Yeah, they would have had constipation, yes. More so, they could have obstipation itself. So they would have features of severe vomiting and severe pain abdomen possibly associated with that. So the feces in flatus is less likely without that history. So they would have had that constipation history. What about the fatal neoplasm or the fatal tumor, organomegaly?
Weight loss.
About the abdominal distension, we're just discussing about abdominal distension.
It will be localized.
Yeah, it would be asymmetrical. It would be based on the organ that is enlarged. If supposedly it's the liver, it would be more on the right side. If it was be a spleen, it would be on the left side. So an asymmetrical distension would more suggest organ enlargement, and the patient might complain of a dragging sensation on that side. So that would be suggestive of an organ that is enlarged. So based on your history, you have to clearly say that it is fluid that is accumulated, not the other Fs that you have. Okay, if it was a female, you have pregnancy as also an important cause for abdominal distension. And in elderly persons, possibly you should also consider a full bladder. Okay, it's not 5 Fs, it is 7 Fs, they say. So full bladder itself, if supposedly there is an acute retention, the patient can complain of an abdominal distension there. So these are the causes. So based on history, you think this is possibly a fluid that is there. So this is an acute onset of abdominal fluid, that is a situs that this patient is come with of 1 month duration. Okay, so that's what you said. Okay, why you asked for history of no pain abdomen? Why did you ask that for? What would it help you? Hello? I think there's a little audio problem on your side, Melvin.
Sir, I guess it's because of the headphones. Try keeping the mic near the mouth, sir, while speaking.
There's a little echo, I think, there. That's it. Yeah, Melvin, tell me.
Yes, so one is it could be due to the feces and flatus. And, in case of fluid, it could be due to spontaneous bacterial peritonitis.
Okay, when you're saying there's pain, what are you trying to infer there? What are you think to rule out or inferring out?
Some infection or inflammation.
Some infection or inflammation. So that's what you'd want to say. And again, remember the onset. Okay, if it's a rapid onset swelling, always you will have a pain that is there. If it's a gradual onset which is occurring, slowly accumulating, the patient may not complain of pain. So it could be an inflammatory process, it could be an infection that is there, or it could be a neoplastic process which can cause pain due to the nerves involvement. And also you have to remember that this fluid which has got accumulated can get secondarily infected. As you said, spontaneous bacterial peritonitis, isn't it? So the fluid which is accumulated can get secondarily infected. So that's why we have to get the history of pain abdomen. And as you said, the other causes like intestinal obstruction, etc., would come with pain abdomen. Yes. The next thing that you asked is no history of swelling of lower limbs.
Yes, sir.
Why
To rule out any cardiac cause or nephrotic syndrome.
Okay, so this patient does not give you history of swelling of lower limbs. So what is your inference? So there is an abdominal distension, but there is no lower limb swelling at all in your history. So what do you think this causes? You have an ascites, but there is no lower limb swelling, no lower limb edema. Normally in a patient with cirrhosis of liver, do you get pedal edema or no?
It's there usually.
Yeah, it's usually you get pedal edema. Pedal edema starts quite early. Ascites will manifest a little slowly maybe, but pedal edema starts early. Yes. So all the mechanisms which cause pedal edema by increased hydrostatic pressure do produce the leg swelling before the ascites would develop. Now here in your patient, you do not have leg swelling, but there is ascites only. So what is the relevance of this? What do you call this? Ascites without pedal edema or ascites with very minimal pedal edema?
Ascites precox.
Okay, so this is what we consider as ascites precox. Okay, so this is ascites precox. Now, what's the importance of knowing ascites, whether it is ascites precox or just an ascites?
So
Why do you have to know that?
It will help us to get to know the cause of the ascites.
Yes, very important. It helps us to get to know the cause of ascites. So when the fluid is localized to the peritoneum, there is no pedal edema like your patient is having. It tells us that the problem is, where is the problem?
Localized.
Is it a systemic problem? It's a localized problem. So it's primarily peritoneal problem. That's what it tells us. Okay. So the pressure is only there. The peritoneum itself is getting. So what are the causes? Ascites without edema.
Malignant peritonitis.
What's the commonest one? Malignant should be the last one. Common one. Common infection which can come there?
Tuberculous peritonitis.
Tuberculous, yes. Tuberculous, correct. Second? As you said, malignant. Okay, I'll take the malignant as a second. Third?
Pyogenic.
Pyogenic, why will it come there? Peritonitis, you mean?
Yes.
Peritonitis does not cause ascites, it's just an inflammation, so that doesn't come here. What else can happen there? Supposedly, this patient consumes alcohol?
Cirrhosis.
Cirrhosis, again, I told you, cirrhosis, the problem is not in the peritoneum, isn't it? Cirrhosis is a systemic problem, so it cannot cause only ascites. Cirrhosis should cause pedal edema. Any other organ inside the abdomen which can get involved in an alcoholic patient other than liver?
Spleen, sir.
Okay, spleen is an effect that does not cause ascites, isn't it?
Pancreatitis.
Yeah, pancreatic. So pancreatic ascites is just ascites. There is no pedal edema. Yes. Any other important cause? This term what you used as ascites precox was described for which disease?
Constrictive pericarditis.
Yeah, that's very important. You have to remember this term ascites precox was coined for constrictive pericarditis. So the problem is not in the peritoneum there, but still the pressure falls on the peritoneum. So constrictive pericarditis is one cause that you have to remember. And one type of cirrhosis can produce this ascites precox. What is that? Which is pretty acute. Your 1 month duration, you say. Where the pressure is too much inside the abdomen. Which is that cause?
Not sure.
Where you have a lot of pressure that's built up pretty rapidly. Something like constrictive, where there's a back pressure falling on the liver. Which is that disease? Obstruction, isn't it? Obstruction to the hepatic veins or the inferior vena cava. What do you call that as?
Budd-Chiari syndrome.
Budd-Chiari syndrome. So please remember, these are the 4 or 5 causes for ascites precox. So ascites precox has to be one of these causes. Can you list the causes again in order of importance?
Yes. One is it could be a peritoneal cause like peritonitis, which is tuberculous peritonitis or malignant peritonitis.
Not any peritonitis. It is specific for tuberculous peritonitis. Yes. Second.
Tuberculous or malignant peritonitis.
Correct.
Constrictive pericarditis.
Yes.
Budd-Chiari syndrome.
Yes. And pancreatic ascites. So these are the possible 5 causes when a patient comes with only ascites and no pedal edema. So it's very important where is in a history, even if the patient gives you history of mild pedal edema, which has decreased now on treatment, we'll have to say that the pedal edema was there. Because if you say that there is no history of leg swelling at all, then we are dealing with one of these 5 causes. You understood it?
Yes, sir.
So it's important for us, even if the patient does not have edema. On examination, does this patient have edema?
No, sir.
No edema at all. Huh? Absolutely dry he is.
Yes, sir. Normal.
Did he, I mean, past history, 2 weeks back, 3 weeks back, no edema?
He didn't complain of any edema, sir.
No, this is because you have to voluntarily ask for it. Because remember, cirrhosis, in standard classical cirrhosis, portal hypertension, you will have pedal edema, because the mechanism of edema in case of portal hypertension is what? Why does the edema happen in portal hypertension? What's the mechanism why this edema, ascites, etc. are happening? There is an increased hydrostatic pressure, isn't it?
Yes.
Why does that happen? What's the basic root cause? Why is there increased hydrostatic pressure? What is happening there in liver cirrhosis or portal hypertension? Why is the hydrostatic pressure increase? Same is the mechanism for heart failure. Same is the mechanism for nephrotic. Same is the mechanism for renal failure. All of them cause edema by one single mechanism, by increasing the hydrostatic pressure. So how does that happen?
So it is the dependent on.
It is dependent on?
It is the dependent part. The feet are.
That's right. But then why does this fluid come out of the space to the interstitium? There is increased hydrostatic pressure secondary to anybody else? Yeah, there's a back pressure. Somebody Siddhartha said. No, there's no capillary damage. There's no capillary damage. That happens only when there is inflammation. Hypoalbuminemia occurs only in certain conditions, not in all. Okay, the renal flow is decreased. Okay, so it results in what? The renal flow is decreased, so there's an underperfusion. So it results in activation of the RAS, resulting in excess of which hormone? I think, yes, somebody has typed in there, aldosterone. So all of these mechanisms increase aldosterone. So this is called as secondary hyperaldosteronism. So be it heart failure, be it renal failure, be it cirrhosis of liver, all of these finally end result is RAS activation, secondary hyperaldosteronism. So in all of them, pedal edema occurs first. Okay, and pedal edema is there even to a significant extent. So when you say there is ascites and there is no pedal edema, we have a very, very few differential diagnosis. So if your history is what you have said, then we are differential diagnosis just remains with those 4 conditions. Okay, you've asked about facial puffiness. Why?
Nephrotic syndrome.
Okay, nephrotic syndrome or the renal failure. Why do you say that facial puffiness is more in renal failure or in that cause? Why does that happen like that? Why is it more common that a patient with renal failure has facial puffiness rather than a cardiac patient? In a cardiac patient, we do not get facial puffiness, whereas in contrast, the renal failure, we get it. Why do you think it happens like that? Why does... Okay, patient with cardiac failure. Okay, affiliated to... Yeah, there's a loose areolar tissue around the eyes. That's correct. But that's there for all patients. But why in renal failure does it go there? And in the cardiac failure, it does not. Again, remember, patients with cardiac failure are usually breathless, isn't it? Will they be able to lie down?
Because dependent position, yes.
Yeah, they would not be able to lie down. They are predominantly sitting. They're predominantly sitting there, and they will not be able to walk around much also. So the edema is more in the legs or the presacral area. Whereas kidney disease patients are generally walking. They're not bedbound, though they might be dyspneic, but they generally are mobile. So the pedal edema is much less there, and it will be more on the face. Cardiac patients are generally sitting, so the dependent part comes down. So Facial puffiness is characteristically seen in nephrotic or kidney injury, especially glomerulonephritis. Also, it can be seen in angioedema. Okay, that is one more condition where you can get facial puffiness. Okay. You've asked for history of difficulty in breathing, orthopnea, PND. Why?
To rule out cardiac cause of ascites.
Okay, you ruled out cardiac causes of ascites. Okay, which are the cardiac causes of ascites?
Congestive cardiac failure.
Anything more specific? Is it congestive or which side heart failure?
Right side.
It's right heart failure. Okay,
Right
so
heart.
remember right heart failure, constrictive pericarditis, and restrictive cardiomyopathy. These are the three causes where you could get a ascites in case of a cardiac disease. Okay, fine. So this one episode of vomiting he has had, what is the relevance of that? Is it relevant?
So probably if you're suspecting intestinal obstruction, then
Okay, but then they'll have multiple episodes. No? There's only one episode per day
in a
on
week.
Yellowish. Not blood stint also. It's not a H.I.M.S. So just one episode of vomiting per day. Okay, you can consider some amount of obstruction there. Okay. No history of blood in stools. Why?
Again, to rule out any bleeding, like
Hmm.
variceal bleeding.
Okay, variceal bleeding. So what sort of history you will get if the patient has variceal bleeding?
There could be, depending on where the bleed occurs, it could be hematemesis, or it could be frank blood in the stools like hematochesia.
Okay. Or you could have melena, isn't it? So what does melena mean? How do you describe melena? Hello?
Hello, yes, sir. Can you hear me?
Yeah. Yeah.
Yeah.
How do you describe melena?
So it'll be black, tar-like
Yes.
stools which are foul
Yes.
smelling and
Foul
sticky.
smelling? Yeah, sticky. They will be difficult to flush. So
Yes.
what does melena indicate?
So it indicates that there is a upper GI bleed.
Upper GI bleed. So what is upper GI?
Up till the ligament of Treats.
Till the ligament of Treats. So till the ligament of Treats, you could consider it as upper GI bleed. So again, remember how much of time, why does this become black? Why does the blood become black?
Long transit time.
Okay, so how much time this blood has to be there in the intestine to become black? How long this blood has to remain in the intestine? Because by chance the intestinal transit time is rapid, even upper GI bleed can present with red stools. You may not have black stools. So what's the minimum amount of time this blood has to present, or this blood has to remain in the GI tract?
Few hours.
Few hours. How much is few? Few hours, 3 hours. How much of time does it need for this black color change to occur? 12 hours is too long.
6 hours.
6 hours also is long. Okay, we'll come to that once we answer the rest of the questions. Okay, hematochesia means, what does hematochesia mean? Frank bleeding. Okay. Yes. Frank blood in stools. So can you get it in portal hypertension?
You can, if the transit time is less.
Okay, otherwise? Do you have varices in the rectal?
Hemorrhoids.
Yeah, you get varices in the rectal also, isn't it? Portal hypertension, one of the sites is hemorrhoids, isn't it? Internal hemorrhoids. So you could get bleeding due to that also. So hematemesis and hematochesia history is very important because that would tell you whether it is significant portal hypertension is there or not. Okay. What's the next symptom that you're told?
Yellowish discoloration of skin and the eyes.
Okay. So what does that indicate?
Yes.
What does that indicate?
So indicates jaundice.
Okay, so there's a jaundice since 1 week, no? It's a recent onset jaundice.
Yes,
It was not there in the beginning. Now the patient is developing jaundice. And does he have high colored urine? Okay.
he
Yellowish
does.
discoloration of the urine and high colored urine. Is it high colored or it's yellowish?
Uh, Yellowish.
Yeah, is it important to know that?
Yes, the
Whether it's
difference.
yellow or whether it's high colored?
Yes, you can differentiate the type of jaundice based on the color.
Yeah, because if it's a
Objective and
hemolytic jaundice,
it
the
could be normal.
urine when they pass will be clear, but on standing it becomes high colored. Whereas
Yes.
if it's a conjugated bilirubin, it becomes yellow. So here, if you're saying it's yellow, then possibly we're dealing with a conjugated bilirubin. So either the problem is in the liver or after the liver. Okay. What's the next thing you said? No history of generalized itching. Why did you say that?
So to
What
rule
is
out
very infer?
obstructive jaundice.
Okay. Why do you get itching in obstructive jaundice?
So because of the bile salts,
Yes.
the bile salts get deposited under the skin.
Okay.
So they
So,
cause
so if it's deposited under the skin, why will they be itching? What is itching? What do you mean by itching? It's a stimulus. It is a sensation, no?
yes.
So how does itching start? Because of bile salts depositing. Histamine, no, that's not the mechanism. What does the bile salts do? What's the effect of the bile salts on the? How are these nerve endings there? There are nerve endings in the subcutaneous tissue. Do
Yes.
we have nerve endings? Isn't it? They are
Yes,
the
sir.
receptors. What are the receptors you know of? The various receptors.
Merkel's, Passinus.
Yeah. So these are all the receptors, isn't it?
Yes,
And
sir.
how are they? You have seen the various shapes of it, no? So there is a nerve ending which is surrounded by what? Why is all those shapes they have? What is it surrounded by? Myelin. Or it's a fat, isn't it?
Yes, sir.
It's fat which is surrounding. So what does this bile salts do to the fats? What's the action of bile salts on the fat?
Degrades the fat. Break down.
Degrades. Any better word?
Break.
Emulsifies. Okay. Saponification. So what happens? This fat gets saponified or emulsified there. So what happens now to the nerve endings?
They're open. Like, they're
They're
exposed.
open. They're exposed, and that is why you get this itching. So remember, that's why you get this generalized itching. So if it is there, it's a very specific feature of obstructive jaundice. Where else can you get generalized itching? Other causes of generalized itching?
So diabetes mellitus.
Okay.
Polycythemia.
Very important is uremia. Okay. Uremia and obstructive jaundice are two important causes of generalized itching. You can get it in case of hypothyroidism. You can get it in skin disorders, etc. But always remember obstructive jaundice and uremia. Okay. Clay colored stools.
So to rule out obstructive jaundice.
Okay. To rule out whether it's an obstructive jaundice. So that's not there. So based on your history, what type of jaundice is this? As of now, based on whatever we have discussed, it looks like
hepatocellular jaundice.
hepatocellular jaundice. Okay, fine. Yes. What's the next symptom? Decreased appetite. So what is the relevance of decreased appetite?
So it could point out a malignancy.
How old is this patient?
30 years.
Do you think malignancy is common at 30 years of age? I'm not saying it cannot happen, but malignancy is not the first thing that we'll want to think of. So decreased appetite. What are the diseases where you have decreased appetite other than malignancy? Common diseases. Loss of appetite is
Tuberculosis.
tuberculosis, isn't it? So tuberculosis, you can have it. Did we consider tuberculosis as a differential diagnosis?
Yes, sir.
Yes, no. So we have to get this. So decreased appetite could be secondary to tuberculosis. Okay. It could be secondary to a chronic illness. Any of the chronic diseases the patient can have anorexia. So it could be also due to malignancy also. Okay. No weight loss. So that rules out quite a lot of diseases. This patient has ascites, isn't it?
Yes, sir.
So do you think weight loss will be manifest in this patient? Even if he has lost weight, will it be able to gauge the weight loss? When there
No,
is
sir.
a fluid, it will be difficult. Okay. But
Yes.
still, if the patient tells you that he has lost weight, then it's significant. Easy fatigability indicating,
Anemia.
okay, could be anemia, could be any of the chronic diseases. Yes. Next slide. Fever. What did you ask that for?
So to rule out any systemic spontaneous bacterial peritonitis,
Okay.
and
What else?
infection itself can act as a trigger.
Okay, infections like hepatitis, correct. Tuberculosis we thought of, malignancy could be. So all these can cause fever. So that's what. History of altered sleep-wake pattern, anytime drowsiness is to rule out.
Hepatic encephalopathy.
Hepatic encephalopathy. So hepatic encephalopathy. Hematochesia, blood in stools and melena. So, okay. So that's already to rule out the GI bleed as a cause. Yes. Next. Okay, so far as we've discussed, so what is your inference so far? What sort of disease are we looking at? We have ascites, we have jaundice, which is of a 1 month duration, isn't it?
Yes, sir.
So what sort of disease is it? It's an acute, subacute, chronic?
Probably chronic disease.
1 month, just 1 month, no? Symptoms are based on your presenting complaint?
It's acute
It's
acute.
an acute disease. So it's an acute disease. So to remember, in liver disease, to say chronic, the minimum time duration that is needed is, to say chronic,
6 months.
6 months. Very important. 6 months. Okay. So if you have some history in the past, maybe I think in the next slide it's coming. So that then it becomes a chronic. Otherwise, whatever you're presenting complaint is an acute disease. Okay. So up to 4 weeks is acute, 4 weeks onwards till the 6 months is subacute, and then more than 6 months is chronic disease. So we're dealing with an acute disease which is presented with only ascites and jaundice. Correct?
Yes, sir.
So what is your diagnosis now? We had those 5 causes of ascites precox, out of which is possible, which is acute and can present with jaundice also.
Budd-Chiari syndrome.
Budd-Chiari. So as of now, your diagnosis is acute Budd-Chiari. Okay, because
Yes.
tuberculosis is chronic, malignancy does not produce jaundice, and then your constrictive pericarditis will not have jaundice, and constrictive pericarditis will have breathlessness, etc. also. Pancreatitis will have severe pain abdomen, again no jaundice. So a condition which is acute, which presents only with ascites and jaundice, is acute Budd-Chiari. Okay, so that's what is an inference till now. Okay, let's go to the past history.
Past history. The patient had similar complaints of abdominal distension, vomiting and yellowish discoloration of skin and eyes 8 months back, for which he was admitted to the hospital ward and was treated with medications, ursodeoxycholic acid, Cilibion and Neurobion. He was relieved and discharged after 1 week. No history of hypertension, diabetes, asthma, TB, or epilepsy. No history of chronic drug intake, blood transfusion, tattooing, IV drug abuse. No history of intake of any herbal medicines, and no history of any surgeries in the past.
So what is your relevance now at this end, what you can say now?
So he had similar complaints 8 months ago, so it becomes a chronic disease.
So this becomes a chronic disease. Does it become a chronic disease because he was in between normal? Na? So what do you call this? There is a chronic disease and then there is an acute manifestation of it, isn't it? So
yes,
this is what we call it as an ACLD. What do you mean by ACLD?
Acute on chronic liver disease.
Yeah, acute and chronic liver disease. Please remember, the most common liver disease that you encounter in your clinical practice is ACLD. It's neither acute nor chronic. It is acute on chronic liver disease. So here is a chronic liver disease because he had 8 months back jaundice, and he had admitted, and then it was relieved with certain medications. Okay. So there is a chronic liver disease, and now it has a acute, or an acute manifestation of a chronic liver disease. Okay. You asked for history of diabetes. Why you asked for history of diabetes? Or just gender?
So generally to rule out any systemic illnesses.
Is there for a diabetic patient who develops a liver disease? Is it relevant? Okay, hemochromatosis is a rare cause. Common diabetic patient has liver disease. Metabolic syndrome. Heard of metabolic syndrome?
Yes.
Melvin? Yeah. So metabolic syndrome, what is it? Metabolic syndrome. Obesity.
Hypertension and diabetes.
Yeah, hypertension, diabetes, dyslipidemia. So they are associated with non-alcoholic steatohepatitis. You heard of it, NASH?
Yes.
So that's a very, very important cause of cirrhosis of liver. It's an upcoming entity, okay? World over, what's the most common cause of cirrhosis of liver?
Alcoholic.
The most common cause is not alcohol. World over, the most common cause of cirrhosis of liver is post-hepatic, okay? Post-hepatic, what we call it as the post-necrotic cirrhosis.
Okay.
Either secondary to hepatitis B or hepatitis C. That is the most common cause of cirrhosis world over. Alcohol is the second cause, and the third cause, which is very much rising up now, is your non-alcoholic fatty liver disease. So NAFLD is a very important disease, which is a disease of the present generation because of the obesity and metabolic syndrome. So diabetes is a very important component of it. So supposedly somebody is a diabetic liver disease, you should consider fatty disease. Okay.
Okay.
Chronic drug intake. What drugs are known to cause this problem?
So anti-tubercular drugs.
Okay, again, remember anti-tubercular drugs produce hepatitis. It produces hepatitis. Okay. Here they deal with the chronic, something like a cirrhosis. So what are the prototype drugs which produce cirrhosis of liver? At least 1 or 2 drugs you should remember.
Steroids.
Steroids, okay, I won't say no, but more important drugs which produce fibrosis of the liver. Amiodarone, please remember amiodarone. Methotrexate, okay, somebody who's on methotrexate for a long time. Who are these patients who are on methotrexate for a long time?
Cancer patients.
Cancer patients, are they on long time? Cancer
Rheumatoid
patients,
arthritis.
rheumatoid arthritis, connective tissue disorders, isn't it? So
Yes.
those are the patients who develop fibrosis of the liver. Amiodarone, where do you use amiodarone, Melvin? Which condition? Where we use amiodarone?
Angina. Antiarrhythmics.
Antiarrhythmic, isn't it? Not angina, antiarrhythmic, used for atrial fibrillation. So supposedly
Yes.
somebody is on that, then you know that these patients can develop cirrhosis of liver. Okay. The other drugs can produce hepatitis. Okay. What's the relevance of blood transfusion?
So to rule out hepatitis B and C.
Okay. Hepatitis B and C. Correct. What about
Also,
tattooing? Yes.
yeah, same. Blood transfusion, tattooing, and IV drug abuse.
For hepatitis B and C. Okay. So please remember hepatitis B and C are the most common cause of cirrhosis. Because if you take the percentage, if you take 100 patients who consume significant alcohol, what is significant alcohol, Melvin?
So 21 units per week in males and 14 units per week in females.
Okay, for what duration? To say it's significant. 1 week?
No.
how long they should be consuming that to develop cirrhosis? 7 to 10 years, okay? So they should be consuming that much. So supposedly you have 100 patients who consume that much of alcohol, and there are 100 patients who is having a hepatitis B and 100 patients who are having hepatitis C positive. What is the chances of them getting cirrhosis? Each of these three groups. You have 100 patients alcohol significant, 100 patient hepatitis B positive, 100 patients who are hepatitis C positive.
Don't know, sir.
What is the percentage for alcoholics? Okay, you can take a guess for alcohol. How many of them will develop cirrhosis?
60%.
60%. That's quite large, na? If that was there, alcohol would have been banned long back. People are still using alcohol. It's less than 15%, 15, not 50. Less than 15% of the people who consume that much of alcohol finally end up in cirrhosis. In contrast, hepatitis B, it's almost 50%, 50% go into cirrhosis. And if you see hepatitis C, it's almost 55 to 60% go into cirrhosis. So supposedly it's hepatitis B positive, that patient's chance of getting going into cirrhosis is much higher. Same with hepatitis C also. And also remember, hepatitis B and hepatitis C also land up in one more complication. What is that?
Acute fulminant.
Okay, that's the acute condition. In chronically,
Hepatocellular carcinoma.
hepatocellular carcinoma. That's why we should be worried about them. Okay, fine.
Okay.
Yes, no history of, what's the next one you have written? No history of taking herbal medications. Yes. No history of surgeries in the past. What's the relevance?
So cholecystectomies.
What would that tell you?
It could have biliary stenosis, like stricture in.
Okay, so obstruction. Okay. Anything else? Again, during surgeries, if the blood transfusion was done, then the chance of infection could be there. Okay, that could be one of the things.
Yes.
Next.
Family history, no history of similar complaints in the families.
Is it relevant, family history?
Yes, sir. In
What's the
cases,
relevance?
so in hemolytic disorders.
Okay, that's for the, yeah, we're talking about hemolytic anemias. Here we are talking about what? Liver disease, isn't it? Cirrhosis of liver.
So inborn errors of metabolism.
Like?
Wilson's and hemochromatosis.
Correct. Wilson's, hemochromatosis. Anything else? Autosomal recessive one? Any other inherited cause you're aware of?
So Dubin-Johnson and Gilbert's.
Okay, that is the jaundice one. I'm talking about cirrhosis. Other than Wilson's, hemochromatosis, any other cause? A young male comes with emphysema as well as cirrhosis.
Cystic fibrosis.
Cystic fibrosis does not cause cirrhosis. Alpha-1 antitrypsin deficiency. Okay. So these are the inherited cirrhosis. So family history is relevant, especially if a young patient comes with cirrhosis. Okay. And if you're considering tuberculosis, then family history is more important. Yes.
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 Personal history. Diet is mixed, predominantly vegetarian. Appetite is reduced. Sleep is undisturbed. Bowel and bladder movements are regular and normal. He has history of alcohol consumption since 5 years. Brandy was consumed about 100 grams per day. Last drink was consumed 1 week ago. History of smoking since 5 years.
So is he an alcoholic? Or he just consumes alcohol?
He's an alcoholic.
When do you say a person is alcoholic, that means he's dependent on alcohol. When do you label somebody as alcohol dependent? You should have some of the dependence criteria, isn't it?
Yes,
Any criteria you're aware of? Any 4 questions we ask?
So I'm not sure of that.
Not sure. You heard of CAGE criteria? CAGE?
Yes, sir,
No?
but not
You
sure.
don't know about. Okay. C stands for cut down attempts. A stands for patient if he is annoyed. G stands for guilt. And E stands for eye opener. So if any one of them is present, then the patient is alcoholic. So this patient is having a significant alcohol, you think? 100 grams of brandy per day. So how much units will it come to?
About 10 units.
10 units for the past 5 years. Okay, fine. But he is continuing to consume the alcohol despite of having the liver disease 8 months back, correct? So he has not stopped it. Yes, okay.
History of smoking since 5 years, about 10 cigarettes per day, 2.5 pack years. No history of high risk sexual behavior.
What's the relevance of that? High risk sexual behavior?
So again, hepatitis B and hepatitis C.
Is hepatitis C spread by sexual route?
Hepatitis B. So.
Is hepatitis C spread or no?
It is
Hepatitis
bloodborne.
B is correct. HIV, hepatitis B is correct. Is hepatitis C spread by sexual route?
No, sir.
Sure, it's not spread.
It's bloodborne, but I'm not sure.
Bloodborne. It's a bloodborne. Yes, the chances are pretty less there. Okay, next slide.
Summary of the history.
Yes.
Here is a 30-year-old gentleman who has history of alcohol consumption.
Hello.
Of abdomen, discoloration weak. There is also history of similar complaints 8 months ago, which was treated and relieved. I would like to consider decompensated chronic liver disease secondary to ethanol consumption.
Okay, you want to modify that a little more?
Acute on chronic.
Yeah, so it's an acute decompensation of a chronic liver disease secondary to ethanol consumption. Now, are you sure this is ethanol consumption only? You want to say this is due to ethanol only?
So most probably because he has a history of consumption, significant consumption.
No, that's what we said. No, only 15% of them will land up with that. And somebody who's taking it for almost 10 years will land up with that. This is a shorter duration of symptoms. I mean, consumption of alcohol. I'm not saying it cannot be, but then it should be a little open. You should be, every patient you will want to rule out hepatitis. Please remember, even there is a significant alcohol consumption, you would want to rule out hepatitis because it is curable. There are drugs that are available for hepatitis B and hepatitis C. For ethanol, we do not have anything to be done. So you can treat the patients with hepatitis B and C. So we should rule out, okay? So we cannot straight away say that this is not related to hepatitis because that's the most common cause, okay? Hepatitis B and C. Okay, why do you say it is decompensated? What is the decompensation this patient has?
So ascites and
okay, ascites is the decompensation, yes.
Jaundice.
Jaundice is the decompensation. So there's a jaundice and there is ascites. But again, please, your history is not fitting into the classical cirrhosis because pedal edema is conspicuously absent in your patient. Okay. What are the other decompensations?
Okay.
But what are the other decompensations a patient with liver disease can have?
Encephalopathy.
Encephalopathy, correct. Then
GI bleeding.
GI bleed, correct. GI bleed, encephalopathy. These are the 4 common ones. What is now coming in, and now we consider one more as a decompensation also, not hepatorenal. One more complication. If a patient with cirrhosis develops that, it is also considered as a decompensation. The next stage of cirrhosis. What's the next stage of cirrhosis? HCC, isn't it? So hepatocellular carcinoma is also considered as decompensation. The patient may not have ascites, patient may not have GI bleed, no encephalopathy, but you do an ultrasound and you find a mass there and it is HCC, it is considered as decompensated. Again, remember the treatment when we go for hepatitis B and C, there is a difference for the patients who have decompensated, there is a difference for the patients who have not decompensated. That's why we have to know very clearly to say this is decompensated or not. Yeah, portal hypertension is a decompensation. That's why we said GI bleed. GI bleed and ascites are features of portal hypertension. So we are not saying portal hypertension as the decompensations.
Okay.
Yeah. So I think that's the history diagnosis, acute decompensation of a chronic liver disease. Secondary, possible due to alcohol as an
So,
etiology, but you would want to rule out other causes also. Yes.
so can we consider Wilson's disease?
Can you consider Wilson's disease? Yes. Okay. Why do you want to consider Wilson's disease?
So he's a young patient.
Okay, so he's a young patient, so you can consider. Yes. Anything else should be there? Wilson's disease is a, sorry, Wilson's disease is a inherited disease, isn't it? So you should have a strong family history. Again, you may not get it in all patients, but yes, more importantly, remember, younger patient with the Wilson's disease come with neurological manifestation. They come with neurological manifestation, okay? And a little older, that is around 30 to 40 years of age, they manifest with cirrhosis. Very rarely we have a combination of both together. We do not have a combination of both together usually, okay? So younger patients, 20 and younger, they come with neurological manifestation. If alcohol was not there in this patient, history-wise, then definitely we would have considered one of the other causes. But since your alcohol is there, and Wilson's is not a common disease, though we have to look for, on examination, we have to look for signs of Wilson's disease, okay?
Okay.
Yeah. Proceed.
General physical examination. The patient
Any other
is
doubts so far? Anybody else? Any other doubts before we proceed? Anybody else has any other doubts? I can't see the chat box. I'm using the chat boxes. I think it's okay. We'll proceed. Yeah, no problem.
Yes. The patient, general physical examination. The patient is a middle-aged male, moderately built and poorly nourished, is conscious, cooperative, well-oriented to time, place, and person. Vitals, 70, pulse rate is 76 beats per minute, which is normal in rhythm, character, and volume, with no vessel wall thickening. There is no radial or radiofemoral delay. Respiratory rate, 16 cycles per minute. Blood pressure is 120 by 80 millimeters of mercury, measured in right arm in supine position. Temperature is 98.6 degree Fahrenheit, measured in the axle.
Okay, what's the relevance of the vital signs in a patient with cirrhosis? What
So,
abnormalities can you get? In the
the
pulse?
high volume bounding pulse.
You can get a high volume bounding pulse. Yes, correct.
Tachycardia can be there.
Tachycardia can be there. It would indicate what? If there is a tachycardia, it would indicate what would you suspect?
Shock.
And the patient has possibly had a GI bleed, so you should be carefully looking at this patient. Okay, so tachycardia would be a sign of either a GI bleed or an infection like SBP or any infection that's there. Yes. Okay, blood pressure, very important. You have to measure the patient's blood pressure in sitting position. Okay, because you should get the postural BP. These patients with cirrhosis are prone to hypovolemia. Again, remember in cirrhosis, all the fluid is in the which space? Fluid is ascites, etc. is in the third space, isn't it? It is in the extravascular space there. So generally they are intravascularly volume depleted, cirrhosis patients. So there we have a intravascular volume depletion. So you should preferably measure the patient's BP in sitting up. So because you will get a lower BP there. And very important, if the BP is low, again, it's a sign of bleed could have occurred, as you discussed with the pulse rate. Temperature, importance?
To rule out fever.
Yeah, to rule out fever due to what? What could be the cause? SBP could be the cause. It could be any other infection. It could be a hepatocellular carcinoma, which produces fever. Okay, so you have to remember. And per se, cirrhosis of liver itself produces fever because the metabolism of TNF is affected. So you get more TNF in the blood, and that's why you get fever. Okay, respiratory rate. Tachypnea, if it is there, it would indicate. What could it indicate if the patient is tachypnic? Could be due to just massive ascites, yes. Could be a respiratory embarrassment because of that. Could be due to pleural effusion, isn't it? You get hydrothorax that's there. So because of that, they can have. And sometimes they have a complication of cirrhosis called as Hepatopulmonary Syndrome.
Yes.
Have you heard of it?
Yes, sir.
So what do you get in Hepatopulmonary Syndrome? What is the classical symptom described or the sign described? The patient becomes breathless in which position?
Uh, sleeping position.
Sleeping position or sitting position? They become breathless at sitting position. Okay, it's called as orthodeoxia, platypnea, not orthopnea, they are platypnea. So sitting position, they are breathless. They're comfortable in lying down position. So respiratory rate can be changing with position. Yes. Proceed.
Height is 170 centimeters, weight 61 kgs. Icterus is present, pallor, cyanosis.
BMI, how did you calculate the BMI?
I use this height and weight. So
Can you use that in a patient who has ascites or edema?
not supposed to use.
Yeah, we cannot infer, we can calculate, but we cannot infer. By 21, you're saying it's normal, isn't it? But this patient may be actually a undernourished patient. It could be a undernutrition that is there. Yes, icterus is present. Okay, fine. No pallor.
No pallor, no cyanosis, clubbing, lymphadenopathy, or edema.
So edema you looked for. Where are the other sites you looked for edema?
Pedal edema.
Pedal edema you looked for, which you said not there. Where else? This patient is walking around or is he bedbound?
No, walking around.
Walking around. Okay. If he is bedbound, you look for what are the other sites? Sacral edema. You look for sacral edema. Look for abdominal wall edema. You should look for edema around the scrotum, etc. Okay. They could have scrotal or penile edema also, but yes, pedal edema is absent. Okay. Proceed.
Head to toe examination. Hair is sparse. Eyes, icterus is present. No pallor. Yellowish pigmentation of the skin is seen. Resting coarse tremors of hands is seen. Parotid swelling, spider nevi, palmar erythema. White nails, flapping tremors, loss of axillary and pubic hair. Dupuytren's contracture, gynecomastia, testicular atrophy are not seen. Angular stomatitis and cheilitis are not seen. Petechiae and purpura are not seen.
Okay, so what are the signs of liver cell failure this patient has?
Sparse hair.
Okay, sparse hair is not specific, but yes, okay, you can consider. Icterus. That's the only sign which should say that liver is involved here. So icterus is present. The other things are not there. Okay. So what would it mean to you? All these signs are usually seen with chronic liver disease. See the two signs which can be seen in acute liver disease. When you say acute hepatitis, what are the signs can be seen in acute hepatitis?
Icterus.
Icterus can be seen. Second, which can appear rapidly. Today they are there, tomorrow morning it will be there. Icterus is one. Second, spider nevi. Okay, spider nevi can come acutely. So these are the two important signs which can occur in acute conditions also. Ascites can occur acutely, encephalopathy can occur acutely. That's different. But in the signs of liver cell failure, jaundice, spider nevi, and if the coagulation factors are affected, you can get purpura, you can get your bleeding manifestations, isn't it?
Yes.
So bleeding manifestations. These three things would indicate acute. All the rest are usually seen in chronic liver disease. Okay. So since none of them is present, so we are still discussing about an acute liver disease here rather than a chronic liver disease. What is that resting coarse tremors of the hands?
So
It's a flapping tremor?
No.
It's not a flapping tremor. So what's the cause for that?
So probably withdrawal here.
Okay, possibly alcohol. Yes, alcohol induced or alcohol withdrawal tremor you're finding. Okay, that could be possible. How do you differentiate this tremor versus a flapping tremor?
We induced the flapping tremor by. So this was resting.
Agreed, it's resting, correct. What's the difference between a flapping tremor and a tremor, as you said, a coarse tremor. So basically, is flapping tremor a tremor?
Not a tremors.
What do you mean by a tremor? To have a tremor, what should be there? There should be a movement which is to and fro, isn't it? So there should be a movement which is to and fro movement. So it goes up and down. That's a tremor. So there is an agonist contracting and an antagonist contracting. So it should be a to and fro movement. Only then we can call it as a tremor. What happens in a flapping? Flap?
It's only one way. Like
It's only one way. It's a jerk. You see, it's only one way. It's not going like this. It's a jerk that you get. So flapping tremor is actually a jerky movement. What is that? It's a myoclonus. It's a negative myoclonus. It's the negative myoclonus where there's a fall. Positive myoclonus is like this, whereas negative myoclonus is coming down like that. So that's how you differentiate. And then, okay, where will you elicit it? Flapping tremor?
In the hand.
Okay, the outstretched hand, isn't it? You will outstretch the hand straight and keep it forward. Where else can you get it? If you do not get it in the hands, where else can you get them? Can you demonstrate it in the legs?
Sole, like feet.
Not in the feet. Not in the feet. Feet won't move. It's at the proximal part of the limbs that you're going to look for. Any idea how do you demonstrate it? Flapping tremors in the leg?
No, sir.
Okay. Anybody else can tell me? I don't know whether, yeah. Anybody can message and tell me how do you look flapping tremors in the leg? Because that's sometimes occurs earlier than the hands. Okay, otherwise we'll discuss that later. If somebody knows the answer, you can message it out there. Yeah, you flex the hip and the knees, yes, and keep the foot flat on the, foot has to be kept flat on the bed. The knees has to be flexed and you keep it abducted little, so the hips will go into abduction like this. Okay. Anyways, I think there are good videos of that on YouTube. You can see that. Okay. Parotid swelling. What's the inference of this parotid swelling?
So it is seen in alcoholic.
Yes, it is seen in alcoholic. Which is the other things that is specific for alcohol? One is parotid, the other one is Dupuytren's contracture. So these are the two things which are classical to alcoholic cirrhosis. All the rest can be seen in other cirrhosis also. Okay. What's the mechanism of most of them, like palmar erythema, spider nevi, gynecomastia? What's the mechanism? Why does this happen? Yes?
Hyperestrogenism.
Hyperestrogenism. Anything better? Any other better way? Better answer? So estrogen levels increase in the blood. If I do a blood estrogen levels, will it be higher in this patient?
No, sir, it will be.
So what is that? It's not only estrogen. Anything else? There's a ratio between the androgen and the estrogen. That gets altered. That gets altered. That gets altered. Not the total estrogen. Yes. How do you look for spider nevi? It's again a very important thing. Spider nevi. Where do you look for it and how do you look for it?
Seen on the chest.
Okay, seen in the chest, upper chest, and the back. That is your SVC distribution territory, correct? And how do you look for it?
Using magnifying glass in broad daylight.
Magnifying glass, huh? It's visible on naked eye, no? Use a pinhead. Okay, a pinhead or a glass slide. Yes, a pinhead or a glass slide. So you're going to, with the pinhead, the blunt end of the pin, you're going to compress the edge of the center of it. And then when you relieve it, you can see the filling, or the glass slide. Okay, so spider nevi, you could get it. Okay, how to demonstrate gynecomastia? What do you mean by gynecomastia and how do you demonstrate gynecomastia? Yes? Is it an inspectory finding or a palpatory finding, gynecomastia?
Palpatory.
It's a palpatory finding. So you should be able to palpate a subareolar nodule. So you're going to palpate the breast there, and under the areola you should have a nodule. Some say that it should be at least 3 centimeters, but even if it is not 3 centimeters, if you have a nodule under the surface of the areola, you can call it as gynecomastia. What are the other conditions where you can get gynecomastia? One or two causes of gynecomastia. Drugs, yes. What are the drugs that produce gynecomastia? Ketoconazole, correct.
Cimetidine.
Cimetidine, correct. What are the other drugs? Spironolactone, very important drug. Any antitubercular drug produces gynecomastia? Antitubercular drug. Which antitubercular drug? Isoniazid produces gynecomastia. Digitalis produces gynecomastia. Okay, so these are the common drugs. Steroids can produce, yes. Anti-androgen drugs can produce gynecomastia. So again, gynecomastia can be unilateral, it can be bilateral, it can be painful, it can be painless. When there is pain, it indicates it's an acute condition. So any condition can produce painful gynecomastia. Painful means it is just starting. Acute, it means it is just starting. Okay, so gynecomastia can be seen with various causes. Okay, testicular atrophy. What do you mean by testicular atrophy, and how do you make out testicular atrophy?
We should use an orchidometer.
You should use an orchidometer. How does an orchidometer look like?
It will be a series of different sized balls.
Okay, so there's beads of different size, not coins, it is beads. So you're going to compare it, and then, okay, that, so you don't have the orchidometer. How can you make out clinically whether the testis is atrophied or not? What is the clinical sign? Yes, testicular sensation. There's nothing, I think somebody is saying coin. There is no coin used for testicular atrophy. It's either Prader's orchidometer or testicular sensation. So how do you check for testicular sensation? Yes, Melvin?
So you press
Yes.
Press on the testis and see whether the patient winces in pain.
Winces in pain, that is what is happening.
Sickening sensation.
Where will they feel the sickening sensation?
Abdomen.
Yeah.
In the abdomen.
Which part of the abdomen? Lower abdomen, upper abdomen? It's in the upper abdomen, above the umbilicus. So why, when there is a squeezing of the testis, you get a sensation in the epigastrium? Why is it like that?
Sure.
Where does the testis originate?
Oh, in the abdomen.
So testis is intra-abdominal organ, it descends down. So the dermatome that it is arising from is about T10. So it's above the umbilicus, you get the sickening feeling. Okay.
Okay.
What's the normal size of the adult testis? A very common MCQ that's asked. Adult size of the testis. What's a normal dimension?
7.
Volume is 20 cc. Yes, Akshay is saying volume. 20 cc is volume. Okay. What's the size? My question was size.
7.5 centimeter.
7.5 is too big, yeah. It's 4.5 into 3.5 into 2.5. That's a dimension. Easy to remember. 4.52 into 3.5 into 2.5. So remember, this is a normal adult size testis. So if there is a testicular atrophy, the size of the testis is decreased, as well as there will be loss of testicular sensation. So please remember, it can be clinically made out. You did not have a Prader's orchidometer. Okay, petechia and purpura. Why does this happen? Petechia and purpura. Why does that happen?
Hypoprothrombemia.
Hypoprothrombemia. Why does that happen? Hypoprothrombemia.
So because it is secreted in the liver.
Okay, it's produced in the liver. Okay, vitamin K dependent factors. Yes, coagulopathy is there. Any other mechanism?
Low platelet count.
Low platelet count, correct. Any other mechanism? Sorry. Any other mechanism? There is a dysfibrinogenemia occurring in cirrhosis because there is increased sialic acid. The sialic acid metabolism does not happen. So since the amount of sialic acid increases in the blood, the fibrinogen gets malfunctioning. So dysfibrinogenemia secondary to increased sialic acid. So these are the three mechanisms: the coagulation, the platelet, and dysfibrinogenemia. So if that is there, that would be a sign of this. So remember, in this entire list of signs that you have, icterus, spider nevi, and bleeding manifestations can be seen in acute conditions also. Okay.
Okay. Yes.
Okay. Dupuytren's contracture. Where do you see the Dupuytren's contracture?
In the third and fourth and fifth digits.
Fourth and fifth. Okay. The little finger and the, yes. So again, it's specific for alcoholics. So you'll have to palpate. It may not be totally contracted. You'll have to palpate the surfaces here and see if there is any thickening. Okay. Because if it is there, it means alcohol is a etiology. Okay. Proceed. Okay. So based on a general examination, we have said that there is icterus is there, and that's the only thing that is there that we have. Okay. What are the general examination findings which will tell us the etiology of cirrhosis? Based on your examination, can you tell the etiology of cirrhosis?
Yes, like alcohol induced can have parotid swelling and Dupuytren's contracture.
Correct.
If there is like wing beating tremors, then it can be Wilson's.
Yes. What else in Wilson's other than wing beating tremors?
Case of Fleishering.
Yeah, case of Fleishering. Correct. Okay, good. Any other etiology? What's the most common etiology we discussed?
Hepatitis.
Hepatitis. So what is the telltale markers of hepatitis on examination? Tattooing, correct. If there is a tattoo on the body, or if there is an IV injection abuse or whatever, IV needle marks or tattoo, which is tattoo is usually used to cover the IV mark. Na? So if there is jaundice and tattooing, then you know this could be a patient could have caused hepatitis, or there is a surgical scar, earlier surgical scar, then he could have developed due to that. Okay. The third cause of cirrhosis that we discussed. What's the third cause of cirrhosis? NASH. So what is the telltale evidence of NASH? How will the patient be?
He'll have hyperlipidemia.
Metabolic syndrome, no? So how will it be? Yeah, he will have obesity. So supposedly somebody is obese. Obesity, if it is there, okay, that would be indicating that this could be a NASH that is there. They could have signs of diabetes or acanthosis nigricans, or skin tags could be there on examination that could make out, that could tell you that this could be NASH. Okay, fine. Yes, proceed.
Per abdomen examination, patient is exposed from the nipples to the mid-thigh region and was examined in supine position. Generalized distension of the abdomen is seen. Umbilicus is central in position and inverted. Corresponding quadrants move equally with respiration. Dilated veins are
What
seen.
are the quadrants of the abdomen?
So 4 quadrants.
What are they?
Left upper, right upper, lower, and right lower.
Okay, so the quadrants are just named as right upper, right lower, left upper, left lower. Okay, correct.
Dilated veins are seen on both sides of the abdomen. No scars and sinuses. Hernial orifices are intact. External genitalia appear normal.
Okay, how do you make out this dilated veins? How do you examine for dilated veins?
So it should be examined in standing position.
Yeah. So you have to very specifically say that dilated veins were examined in standing position, because in supine position they may not be visible. Are just dilated veins are enough for us, or anything more?
So the direction of flow.
No, direction of flow is correct, but then when you want to say the veins are very significant, you have to use one more word. Dilated, tortuous. Okay, so to say it is very significant. So tortuous veins are seen, and you're going to say, where are they visible? Are they visible in the center, around the umbilicus? Are they visible in the flank? Are they visible in the back? So which veins are relevant for us?
So the central
Or which are the
ones.
veins which you are going to? Okay, the center ones are also important. I'm not saying it's not. The veins that are very important for us to look for the dilation, direction of flow, is the flank veins. Okay, flank veins. And do you want to look for lumbar veins in the back? What's the relevance if you find dilated veins in the back? Which of the etiologies can have that? Okay, it's a very important sign of Budd-Chiari syndrome. Okay, Budd-Chiari syndrome, the IVC is blocked. So the abdominal veins become more, the abdominal, anterior and posterior abdominal wall veins are the ones which bypass it. So if you have veins in the back or the lumbar veins, it is pathognomonic of Budd-Chiari syndrome. So if you're suspecting Budd-Chiari, you should make sure that you examine the back. Okay.
Okay.
Continue.
So this is a picture.
So abdominal distension you're finding. Dilated veins are not, okay, there are some veins, but they're not appearing tortuous. Okay, flanks are full, isn't it?
Yes, sir.
So that means that this patient has fluid in the abdomen. It can be due to fat also. Flank fullness can be due to fat also, but then it is more suggestive for this one. Okay, it's not grossly distended. Okay, it's not grossly, but it's more in the flanks, not in the center. Okay. Okay. Continue.
Palpation, superficial palpation, there is no local rise of temperature or tenderness. On deep palpation, there is no guarding or rigidity. Liver is palpable, a size of about 10 centimeter below the costal margin, firm in consistency, smooth surface, and rounded borders. Spleen is palpable 2 centimeter below the costal margin by dipping method, and it is not tender. Kidneys are not palpable.
Okay. So liver is palpable, isn't it? So
Yes.
10 centimeters below the right costal margin. So how much is normal?
5 centimeters.
5 centimeters is normal liver. Where did you
Shouldn't
measure
be
this 10 centimeters?
in the
You written 10 centimeters below the costal margin, isn't it? At which point did you measure? Mid-clavicular line. So, okay, mid-clavicular line, 10 centimeters, is it normal?
Not normal.
How much is the liver palpable normally in the mid-clavicular line?
It's just palpable.
Just palpable, less than a centimeters. Okay. And you said, and if you see the surface marking of the liver, it starts from the right lobe in the lower part here. And as it comes, the left lobe of the liver. Where is the left lobe of the liver located? Which area? Which region it is located in?
Sternum. Epigastric.
Yeah? Epigastrium. So it's located in the epigastrium, isn't it? Left lobe is located in the epigastrium. In the epigastrium, left lobe, if you can imagine your diagrams of anatomy, there the liver can be palpable. Up to 5 centimeters of liver is normal in the epigastrium. But in the midclavicular line, please remember, 1 centimeter of liver is also just palpable. So anything more than 1 centimeter is abnormal. Here you're saying there is a 10 centimeter liver. It's a really big liver. Okay.
Yes,
that is below the costal margin. So it's a really large liver. And then you say it's firm in consistency. So what does that mean? Firm consistency.
It's
Where do you get firm? Where do you get hard? Where do you get soft?
so soft is normal liver.
Soft may be normal liver. What are the abnormal conditions where you can get soft liver?
Acute in cases of fatty liver.
Yes, fatty liver you get soft liver, correct. Fatty liver you can get soft liver, and even in acute enlargement of the liver, as it occurs maybe in case of typhoid, enteric fever, you can get soft liver. Okay, firm liver,
In case of cirrhosis,
In case of cirrhosis, yes. Hard liver,
malignant hepatocellular carcinoma.
yeah, hepatocellular carcinoma, correct. Smooth surface you mentioned. If it is nodular, what does it indicate? Nodular surface.
So nodular indicates cirrhosis.
Okay, it could be due to cirrhosis, or what else can be nodular? Could be malignancy itself, isn't it? Could be malignancy or a secondaries. It could be nodular in that. Okay. Say the borders are rounded. What does that mean? Rounded borders. When do you use the word rounded borders? When do you use the word sharp borders? So you have a firm liver, isn't it?
Yes.
Firm liver, will it have a rounded borders or a sharp border?
Should have sharp borders.
Should have sharp border. Whenever you say firm, the border should be very clearly felt. You could feel the borders, isn't it, in your patient? So it is a sharp border. Soft livers generally have a rounded borders. Soft livers, like in case of fatty liver, they have rounded. Okay, soft means you're not able to feel the liver itself. It's so soft, you can't easily feel. When you're saying it's a firm liver, that means the liver is easily felt. It should have sharp borders. Okay, so you should be careful in saying. It goes hand in hand. A firm liver has sharp borders. A soft liver has rounded borders. Clear?
Yes.
So if you're a firm liver, that should have a sharp borders only. Okay. Is it tender or not? Is the liver tender?
Non-tender.
Non-tender. So what are the causes of tender hepatomegaly?
Hepatitis, hepatocellular.
Causes of
Hepatitis,
hepatocellular carcinoma, correct?
Any abscesses?
Abscesses in the liver, good. More important causes. Abscesses, whichever abscess, be it pyogenic or amoebic, very important. Heart cardiac condition.
Congestive liver.
Right heart failure. Yes, right heart failure produces a tender liver. Hepatic infarcts, when there is an infarct in the liver, produces a tender liver. So can you repeat the causes of tender liver?
Yes. In cases of hepatitis, hepatocellular carcinoma, abscesses.
Yes.
In cases of right heart failure.
Correct.
And hepatic infarcts.
Hepatic infarct. Also in acute Budd-Chiari. What happens in acute Budd-Chiari? There is a lot of congestion in the liver. So that also produces tender liver. Okay. Coming on to spleen. Spleen is palpable 2 centimeters below the costal margin. So is the spleen normally palpable?
Not palpable.
Not palpable. So 2 centimeters means a mild splenomegaly.
Yes.
Okay, so there's a mild splenomegaly that you found in this patient. Okay. Proceed.
Yes. Measurements. Abdominal girth was 96 centimeters at the umbilicus. Xiphisternum to umbilicus is 25 centimeters. Umbilicus to pubic symphysis is 15 centimeters. Umbilicus to anterior superior iliac spine, right side was 20 centimeters, left side was 20 centimeters.
What's the relevance of these measurements?
So they help us to rule out pelvic masses.
What pelvic masses do you expect in a male?
In a female.
Yeah. In a male, this is irrelevant. Okay. So it's not necessary to do it. Abdominal girth, maybe it's needed, generalized, because you may have to, when the patient is started on treatment, you want to know whether it is improving or it is worsening, then maybe the abdominal girth is important. Otherwise, all the other measurements are more important in a female, okay, to rule out pelvic mass. Okay.
So this was the enlargement.
That's the liver enlargement you felt?
Yes.
Okay, it's quite large. Okay. So what conditions you get such big livers? Such a big liver? Which is not tender. Okay, fatty should have been soft, no? Should have been soft. Huge
HCC.
liver. Hepatocellular carcinoma. Always remember, hepatocellular carcinoma is the cause where you get a big liver. It's almost up to the iliac fossa you're seeing there. So hepatocellular carcinoma is one thing that you have to always think of. All the other conditions. Do you expect a liver enlargement in cirrhosis of liver?
No, sir. It's usually like shrunken.
Usually it's shrunken. Okay. So unless there is a superadded hepatocellular carcinoma, you do not get it. Rarely you could get such big livers if there is a abscess in the liver sometimes, or sometimes with metastasis, but you don't get such big livers unless it is hepatocellular carcinoma. Okay.
Percussion. Liver dullness was felt upper border, fifth right intercostal space on full expiration. Lower border extends 10 centimeters below the right costal margin on the mid-clavicular line on full expiration. Liver span, right lobe was 20 centimeters, left lobe was 11 centimeters. Shifting dullness is present.
What's a normal liver span?
13.
Around less than 13 centimeters, 10 to 13 centimeters is normal. So here you have almost 20 centimeters. So it's a big one. Okay. Shifting dullness is present. Okay, fine.
Auscultation. Auscultation, normal bowel sounds are heard, no venous hum or arterial bruit, no bruit heard over the liver or the spleen.
It's very important. When you such a big liver that's there, you will have to auscultate for a bruit on the liver. Okay. Because yes. What about the veins? You didn't tell me anything about the veins on palpation. They weren't significant.
We didn't.
They weren't tortuous. You could not find the direction of flow.
No, sir.
Was it not that?
No, sir, it wasn't that significant.
Okay. What's the importance of knowing the direction of flow?
So it tells us about the obstruction.
Okay, so can you explain it to me?
So in cases of when there is opposite direction
What's
of
a normal direction of flow?
Normal is from the center to the outwards.
Okay, so it's away from the
umbilicus.
Away from the umbilicus. Normal is away from the umbilicus, correct?
In superior vena cava obstruction, it will be like upper towards the umbilicus on the upper part and away in the lower part.
Okay, so when there is an SVC obstruction, all the blood has to reach the heart through the IVC, isn't it?
Yes.
So the flow will be from above downwards. So everything will go down in case of SVC obstruction.
In case of
IVC obstruction,
it will be away from the umbilicus itself.
It will be away from the umbilicus. No, IVC obstruction.
The upper part will be away, sir, and
upper part will be away. Lower part will be towards. Because if the IVC is obstructed, all the blood has to reach the heart through the
superior
SVC only. So the blood has to go from below upwards. Okay. What about in portal hypertension?
So there'll be caput medusae.
So what's the flow in caput medusae? Direction.
Away. Sir.
Normal flow. So remember, the flow is away from the umbilicus. Normal. In portal hypertension and normal, the flow is away from the umbilicus. That means above the umbilicus is below upwards, below the umbilicus is above downwards. So you have to be very clear about the flow, because if a patient has IVC obstruction or Budd-Chiari we were thinking of, such a big liver is there, jaundice is there, ascites is there with no pedal edema, Budd-Chiari becomes a very important cause for us. So again, we'll have to carefully look for the flow, because in Budd-Chiari, what flow will you get?
IVC obstruction.
IVC obstruction flow will get. Okay. Any other clinical sign you can make out for Budd-Chiari syndrome? Any other clinical sign will tell us that this is Budd-Chiari syndrome?
Harvey's.
Yeah.
Harvey's sign.
Harvey's sign is your milk of the ring. Anything else which will tell us? IVC is obstructed, na? So what will be absent? Somebody in the chat is answering. What will be absent? If I compress on the liver, what should normally happen? The JVP should
Rise because of
rise,
hepatojugular.
isn't it? So hepatojugular reflux should happen. What happens in Budd-Chiari syndrome?
There is IVC obstruction, so
So-
there will not be.
The absent hepatojugular reflux. That's a very important sign that you have to make out. So normally, also if I compress on the liver, the JVP should be little prominent. But if that does not happen, that's a sign of Budd-Chiari syndrome. So when you have such a big liver and a patient is having jaundice and having only ascites with a small spleen that is there, your Budd-Chiari syndrome becomes a very important cause. And we have to carefully look for veins, the direction of flow of the veins in the back of the patient, and then you have to check for abdominal jugular reflux. So only then can you make out what is the cause. Okay, proceed.
Yes. Systemic examination, all the other systems are normal.
What do you look for in these systems?
So in respiratory system, we should look for the, there could be pleural effusion,
Okay, correct. Which side will the pleural effusion be?
right-sided.
Right-sided. Okay, right-sided is more common than left-sided. It can happen bilaterally. Why does it happen? Why does it fluid go through the? How does it reach the pleural space? How does it reach the pleural space from the peritoneal space? Yes, there are some small pores, or as somebody has written, channels in the diaphragmatic area. You will have that. Through that it goes more on the right side. Okay, can happen on the left side also. Yes, so you look for pleural effusion, correct? What else? You have written per abdomen, again normal when you have all the findings in per abdomen.
So that's mistake, sir.
So gross mistake. Cannot be. You have to be careful. Okay, cardiovascular system. What do you look for?
There will be raised JVP. There could be systolic murmur,
Why systolic murmur?
hyperdynamic circulation.
Okay, if there is a hyperdynamic circulation, you might get a systolic murmur. If there is anemia, you can get a systolic murmur. If I consider this as ascites precox, so it could be constrictive pericarditis. So what could you get? If it's constrictive pericarditis, what's the cardiac finding? Muffled heart sounds, correct. Muffled heart sounds could be there. You can get something called as a pericardial knock. Pericardial knock, and rarely you could get a pericardial rub also. Okay. Now a system examination, what do you look for?
So we look for higher mental functions.
Correct.
To rule out hepatic encephalopathy. Then
Correct.
constructional apraxia we should look for.
So how do you do that, constructional apraxia?
So you ask him to draw a clock.
Ask him to draw a clock, yes. Anything more simpler? Any more simpler things that can be done? Draw a clock, correct? There's something called as a number connection test. That's the easiest one and supposedly the earliest one to get abnormal is something called as a returns test or the number connection test, where you write some 25 numbers in random order and ask the patient to connect it in sequence. But ask him to connect it in sequence. Normally, he should be able to do the connection within 30 seconds. So if he is taking more than that, that's a very important sign. Okay. What's the earliest symptom of hepatic encephalopathy?
Daytime drowsiness and alteration of sleep wake pattern.
So that's the earliest symptom. The earliest sign of hepatic encephalopathy?
Flapping tremor.
Flapping occurs later. Earliest sign is number connection test. Okay, that's the earliest sign. Returns test is the earliest sign. What else you look for? Hepatic encephalopathy nervous system examination other than apraxia?
Flapping tremors.
Flapping tremors, very important. Is flapping tremor specific for hepatic encephalopathy?
No, sir.
So why do you get hepatic flapping tremors in hepatic encephalopathy? What's the mechanism? Why does that happen like that? Why is they not able to hold it straight like that? When you're asking him to outstretch his hand, what are you planning? What are you doing? What are you asking him to maintain?
Extension.
You're going to ask him to maintain a posture, isn't it? So there is a joint position, or the proprioception is to be maintained. Now, in case of hepatic encephalopathy, due to the various toxins like ammonia, all of them suppress the reticular activating system. The RAS gets suppressed, and there is a momentary loss of joint position sense. So the hand goes down, but the patient is momentary, so he'll realize it and he gets corrected. So there is a momentary loss of joint position sense due to the suppression of the reticular activating system by the hepatic toxins that is there in the hepatic encephalopathy. Okay. What are the other conditions where you can get this flapping tremor other than hepatic encephalopathy? You can get it in uremic encephalopathy, correct? You can get it in also in case of
Vernix.
No, not in vernix. You don't get it in vernix. You get it in case of type 2 respiratory failure. That is when there is hypercarbia. So whenever there is carbon dioxide increases, you get it. You get it in uremia. You also get it in case of certain drugs. Okay, some drugs like anticonvulsants, etc. You can get this flapping tremors. So carbon dioxide narcosis, uremia, as well as hepatic encephalopathy are three important causes. What else will you examine for hepatic encephalopathy? Nervous system?
Deep tendon reflexes.
Deep tendon reflexes, very important. You will be examining for whether the reflexes are exaggerated. The patient can have bilateral extensor plantar. Yes. So that is what you examine in the nervous system in a patient with hepatic encephalopathy. Yes. Proceed.
Provisional diagnosis. Decompensated acute on chronic liver disease with moderate ascites and portal hypertension with no features of hepatic encephalopathy with CTP score of C, probably due to chronic ethanol consumption.
How did you calculate the CTP score?
So there are 5
Yes.
components: serum bilirubin, serum albumin, ascites, hepatic encephalopathy, and prothrombin time.
So how did you make out those values? They're all lab values, na?
So we
Clinically we can't. Clinically we can't because the bilirubin also has to have a value. Prothrombin time has to have a value. Ascites has to have a value. Encephalopathy, sorry, ascites you can clinically make out. Encephalopathy you can clinically make out. Albumin also has to value. So only ascites and encephalopathy, you cannot calculate the CTP score based on your just clinical. You require the laboratory values. So if you have the laboratory values, then you can. Okay.
Yes.
So say here it's portal hypertension. What made you say it's portal hypertension? What are the signs that were there to say portal hypertension?
Splenomegaly and ascites was there.
Okay. Splenomegaly and ascites. What's the third sign that would have been there?
GI bleed.
Okay, GI bleed. More importantly, GI bleed, correct. That's the effect. Portal hypertension. Veins, isn't it? Abdominal veins. Abdominal dilated veins which are flowing away from the umbilicus. So that are the triad. So those three, if it is there, which is the most important one of the three, without which you cannot diagnose portal hypertension?
The vein.
Ascites or dilated veins?
Dilated veins.
No.
Oh, no. Spleen is the most important.
Yeah, spleen is the most important one. Without splenomegaly, you do not have portal hypertension. Without that, you cannot make out portal hypertension.
Yes.
So, do we have time or is it up? Organizers, are we supposed to conclude?
Sir, we can continue, sir.
Continue. Okay. So, splenomegaly, what's the cause for splenomegaly in portal hypertension? Why does it happen? Why does the spleen enlarge? Yes, why does the spleen enlarge?
The pressure is more, sir. So
Pressure
there'll
is
be
more. So it's a back pressure, isn't it? It's called as
yes.
the congestive splenomegaly. It's the congestive splenomegaly that you get in portal hypertension. Now, supposedly you're examining this patient and you find a spleen, and then you go in the evening and you find the spleen has disappeared. Are you happy?
No, sir.
Why? What does it mean? The spleen has disappeared.
Necrosis.
Necrosis. How can the necrosis happen, man? Overnight necrosis. You said it is a congestion, isn't it? You only said pressure is there on the spleen.
Rupture.
Rupture of what?
Capsule.
Splenic capsule. Huh? That is pretty rare. Why did the spleen disappear? That means the pressure, the other end has opened. Which is the other end? The pressure has to decompensate. Nah? It has to get relieved. So opening from the other end. Varices, isn't it? So remember the variceal bleed. It's an ominous sign. The spleen, if it is absent, that means the patient has already had a bleed. So if a patient comes with acute bleed, variceal bleed, you may not get a spleen because the spleen would have got decongested. The pressure has relieved. Clear? So when you do not have a spleen in a case of portal hypertension, you should be worried because there is an acute GI bleed, variceal rupture has occurred. So that is what you have to remember. Okay. So this is your final diagnosis that you're given. What are the other complications of cirrhosis of liver?
So hepatocellular carcinoma.
Correct?
Then portal hypertension.
Portal hypertension is already there.
Hepatic encephalopathy.
Okay.
Systemic, there can be infection of the fluids, so SBP.
SBP, correct.
There can be shock due to bleed.
That's part of portal hypertension.
Hepatorenal syndrome.
Hepatorenal syndrome.
Hepatopulmonary syndrome.
Hepatopulmonary syndrome.
Cholecystitis can be there.
No, cholecystitis is not a complication.
Due to stone formation.
No, it doesn't happen with cirrhosis. You have to know this list of complications, very commonly asked both in theory as well as viva.
Thrombocytopenia.
Okay, okay. Coagulopathy. Okay, coagulopathy and thrombocytopenia. Agreed. Okay.
Bone disorders.
Okay. Cirrhotic osteodystrophy. Correct.
Peptic ulcer.
No, peptic ulcer is not a side effect.
Portal vein thrombosis.
Okay, portal vein thrombosis. That's a feature of hepatocellular carcinoma. Portopulmonary hypertension. Hepatic hydrothorax. Portal gastropathy. So these are the complications of cirrhosis of liver. So in every patient with cirrhosis, we are supposed to look for all these complications. Okay, so how do you suspect hepatocellular carcinoma in this patient? What will make you suspect a hepatocellular carcinoma?
Pain in the mass.
Okay, pain. Okay, pain in the mass, correct. Okay. Tender liver, okay.
Loss of weight.
Okay, loss of weight. Enlarged liver. Again, remember, you do not get enlarged liver in cirrhosis, isn't it? So if you have an enlarged liver, either we are dealing with hepatocellular carcinoma, or there is an abscess that is there, or it's a Budd-Chiari. So you do not get enlarged liver in cirrhosis. These are the causes where you can get enlarged liver in cirrhosis. And they can develop florid spider nevi, they can develop clubbing, and they can come with worsening ascites. The ascites which was very much controlled with drugs, all of a sudden the ascites is worsening, you should always suspect hepatocellular carcinoma. So how do you confirm hepatocellular carcinoma?
Biopsy.
Okay, any simple blood
Imaging
test can be done?
alpha fetoprotein will be increased.
Alpha fetoprotein levels will be elevated. And if you on the ultrasound, if you find portal vein thrombosis, if it is seen, it is also a marker of hepatocellular carcinoma. And now we don't do biopsies, we do something called as a triple phase CT scan of the abdomen. So the arterial phase, the venous phase, and the venous wash phase, you have specific findings. So we no longer do the biopsies, we do something called as a triple phase CT scan of the abdomen. And through that, you can make out whether it's a hepatocellular carcinoma or not. Okay. So these are the complications, and this is how you are supposed to deal with this patient. So any investigation you have of these patients? Reports are there.
So reports are there.
You know the reports?
He had increased SGOT, so
Okay. SGOT or SGPT?
SGOT was double of SGPTs.
SGOT was double of SGPT. So what does it indicate?
Alcoholic liver disease.
No. Alcoholic, you don't get SGOT more than SGPT. You're saying AST more than ALT, na? Not ALT more than AST.
No, sir. AST was double.
AST was double. Okay, 2:1 ratio. Okay. Okay. Any other abnormality? Thrombocytopenia. Okay.
It was 80,000 cells.
Okay.
Prothrombin time was prolonged to 37 seconds.
Okay, so prothrombin time also is prolonged. Yes.
Yes, sir. Albumin was decreased, globulin was increased.
Okay, so albumin was decreased, prothrombin time was prolonged, SGOT, SGPT is increased. Now, which of these are a marker of acute liver disease and which of this is a marker of chronic liver disease?
Albumin is chronic liver disease. So.
Albumin is a chronic liver disease, so this patient has definite chronic liver disease. Which is the marker of acute liver disease?
Prothrombin time.
Okay, so prolonged prothrombin time is a marker of acute liver disease in this patient. So definitely this patient has an acute on chronic liver disease. Okay. Any other investigations?
So rest were normal.
What about the ultrasound was done?
No, sir, it was not yet done.
Not yet done. Upper GI-scopy?
No, sir, only blood investigations were done.
Only blood investigations were done. Ascitic fluid also was not done?
Not yet, sir.
Okay, so you require the ascitic fluid to be tested in this patient?
Yes, sir, to see for the protein and SAG.
Okay, what is SAG?
Serum.
Yes.
Serum albumin ascitic gradient.
The serum ascitic albumin gradient. Okay, so based on that, you classify it as
high SAG and low SAG. So if it's more than 1, it is high SAG.
More than 1.1, yeah, it is high SAG.
And
it is
less than
suggestive of portal hypertension. More than 1.1 is suggestive of portal hypertension. Okay, so that's very important because this patient has only ascites. There is no pedal edema. So what do you expect the SAG to be? High SAG?
No, sir, low SAG.
So it's only ascites, no portal hypertension according to clinically you don't have pedal edema at all. So it could be tuberculous abdomen or a hepatocellular carcinoma, or it could be a Budd-Chiari syndrome. You might get a low SAG ascites in this patient. So SAG is very important. Okay. And what are the investigations you want to do?
So imaging studies like USG abdomen and CT scan.
Okay, USG abdomen. What are the things that you look for in a cirrhosis of liver in ultrasound abdomen? What are the things that you want to examine?
So texture size of the liver.
Okay, texture and size of the liver, correct.
Portal vein.
Portal vein, correct.
And gradient.
Gradient is little difficult on ultrasound.
Spleen. The spleen.
Sometimes the spleen you may not be clinically make out. So you can look at the spleen, size of the spleen, correct.
Any enlarged nodes.
Any enlarged lymph nodes if it is there, correct? Ascites, if clinically you're not able to make out ascites, you can make out ascites based on the clinical signs. The ultrasound can tell you. Also in the liver, what you look for? In the liver, you want to look for? An ultrasound you can look for. Is there a nodule, isn't it? Hepatocellular carcinoma. You can make out if there is a big nodule there. You can see if there is thrombosis, which will all be evidence of a hepatocellular carcinoma. So size of the liver, the ecotexture of the liver, the surface of the liver, if there is a big nodule, if there is a vascularity, if there is a thrombosis, all those things can be made out in ultrasound. So ultrasound is a very, very important test for cirrhosis of liver. Yes, caudate lobe hypertrophy in ultrasound. Which condition you get it? It's a specific sign of Budd-Chiari. So remember, in Budd-Chiari syndrome, you get caudate lobe hypertrophy because the veins which are going there is separate from the others. So if you see a caudate lobe hypertrophy on an ultrasound, it is suggestive of Budd-Chiari syndrome.
Yes.
Okay, then you do the upper GI endoscopy to look for
Varices.
varices. That's basically needed for that. Renal function test you want to look for?
Serum creatinine.
Yeah, serum creatinine, because you want to know whether the patient is going into hepatorenal syndrome. If there is any complication like that, you want to rule out. Yes. Okay. So these are the investigations. So we don't know the reports. Okay. So clinically, whatever you're told, it looks like a big liver. So the possibility of a Budd-Chiari syndrome or a hepatocellular carcinoma is much probable than any other cause of cirrhosis in this, because you do not get such a big liver in normal cirrhosis. Okay. So it has to be confirmed by your alpha fetoprotein or any of the other investigations.
Okay.
Any other slides?
So treatment.
Okay, so treatment. Treatment basically we require to have the diagnosis, otherwise, okay. So if it is cirrhosis of liver, portal hypertension, ascites, how would you treat? What are the things that you want to treat?
For the ascites,
For the ascites, what do you do?
Diuretics and paracentesis.
Okay, what's the first thing that you do for ascites?
Diagnostic paracentesis.
Okay, that is done, diagnostic, then treatment.
Therapeutic.
Therapeutic is done only if it is a very massive ascites. So you would want to restrict the salt restriction and fluid restriction. That's a basic thing that has to be done. Okay, otherwise your drugs won't work. Okay, then you start the patient on diuretics. What is the diuretic of choice?
Spironolactone.
Spironolactone. Why is spironolactone a drug of choice for this?
Potassium sparing.
Potassium sparing, agreed. But then most important thing we discussed in the beginning, isn't it? Cirrhosis is a state of secondary
Aldosteronism.
Yeah, cirrhosis is a state of secondary hyperaldosteronism. So the drug that we are going to use will be a aldosterone antagonist. And that is why spironolactone is a drug of choice. But for all practical purposes, your spironolactone is a weak diuretic. The diuretic effect is not so strong, so we have to combine it with furosemide. So what's the dose? What's the dose of furosemide? What's the dose of spironolactone? How do you start and how do you increase it?
So up to 400 mg can be given. We start with 25 mg in 3 doses per day.
Okay, so minimum start with 100 mg and you can increase spironolactone up to 400 mg. Whereas furosemide, you start with 40 mg and you can increase up to 160 mg. So total 160 and 400. 4 times you can increase it. And if it's still not responding to that, that's when we call it as refractory ascites or diuretic resistant ascites. What do you do in such conditions?
Paracentesis.
That's where you'll have to do a therapeutic paracentesis. What do we have to do when you do a therapeutic paracentesis? We have to
Give
supplement
albumin.
albumin. How much of albumin?
1 gram per liter of fluid.
Okay, 1 gram per liter of fluid that is being removed. Okay, fine. It still does not work. Ascites is still worsening. What else can you do? Yes, you can subject the patient to a procedure to reduce the portal hypertension, like you can do the TIPS, or the patient can be subjected to a transplant or something like that. That could be the treatment. Okay. How do you treat the portal hypertension?
So we give beta blockers.
Okay. Beta blocker. Which is the beta blocker of choice?
Metoprolol.
Is metoprolol the drug of choice? Propranolol is the drug of choice. Okay. Propranolol is a drug of choice, beta blocker that has to be given. Okay. And
Yes.
then what else you do for the varices? If you see the varices,
Tips can be done.
TIPS is not for the varices.
Banding.
Banding. So you do the banding for the varices. Okay. And then you abstain from alcohol, and then yes, the specific treatment would be
Liver transplantation.
yes, liver transplantation. And yes, based on the other complications, you will manage the other complications also. If you have SBP, you will manage that. If it is coagulopathy, thrombocytopenia, you'll have to manage that. So all those complications have to be managed.
Yes, sir.
Yeah. Any other doubts or clarifications?
So hepatoprotective drugs, do they have a role?
What are the ones? Which are the ones? Hepatoprotective drugs.
Cilibion.
Okay. So Silibon and N-acetylcysteine, etc. Their role is limited for acute hepatitis. Okay, fulminant hepatitis secondary to paracetamol or something like that, where you have your glutathione which is getting deficient, and because of that, you can supplement that. So in acute hepatitis, your N-acetylcysteine, etc. has a role. But once fibrosis is set in the liver, like it occurs in cirrhosis, there is no drug which can reverse it. So the only treatment that you could have is a liver transplantation. Acute hepatitis, it has a role, but not in cirrhosis.
Yes.
Any other query? You can stop sharing your slides. What is, I can't see. Okay. So people say how to differentiate massive versus tense ascites. So what's the difference between a massive ascites and a tense ascites? So tense ascites is a condition where there is 2 liters of fluid. That means fluid thrill has appeared. That is where you say the tense ascites is. Massive ascites is a condition where the fluid is much more. How much of fluid can be accumulated in the peritoneum? How much of fluid can a peritoneum accumulate? Anyone? How much of fluid can get accumulated in the peritoneum? The peritoneum can accumulate as high as 60 liters of fluid. Okay, so that much of fluid can be accumulated in the peritoneum. So it's a big space there. But remember, the bowels are there. The bowels are floating as the fluid gets accumulated at the bottom. But as the fluid accumulation increases, the mesentery can't stretch more than a particular limit. The mesentery will not be able to stretch. So that time what happens? The bowels get submerged. Bowels get submerged and the fluid will come over the bowels. So once the fluid comes over the bowel, what is the clinical sign will be there? Once there is only fluid, the bowel is submerged under that. The only clinical sign that you will have is fluid thrill. Till then, you can get shifting dullness. So the clinical entity, if you have shifting dullness and fluid thrill together, that is called as tense ascites. But massive ascites is a condition where you have only fluid thrill. Okay. Again, remember, for getting shifting dullness, you require around 1.2 liters of fluid. And to get fluid thrill, you require around 2 liters of fluid. So That's the arbitrary numbers that we have. There's no reference as such, but then that's the way it is. If there is veins are superficial and not dilated, do we need to see the diet? As far as if you are able to milk the veins, you can look at the flow. If the veins are not big enough, then possibly you will require to, you may not be able to make out the flow. But then if it is dilated, if you are able to milk the veins, you should be able to look at those. Incidence of hepatitis B and C after blood transfusion in clinical practice is practically not there. Okay, after 2003, once all the blood banks have been mandatory testing for hepatitis B and C is there, so it's practically not there in the setting now. Before 2003, the chances of hepatitis B and C through blood transfusion was very high. Now it's not there. So practically not there, but then we have to ask that history for the rare possibility. Exact percentage I will not be able to tell you, but it is once this blood bank and all the blood banks have been accredited and there is testing done everywhere, so the chances are practically not there. Yes, any other questions? Spider nevi significant number, again it's 5 or more is considered to be significant, but again remember spider nevi is not a specific sign of cirrhosis of liver. It can be seen in many other conditions like pregnancy. It can be seen in thyrotoxicosis also. But 5 and more is significant. Okay, if they ask you a number, 5 or more is significant. Role of amino acids in treatment. Yes, in hepatic encephalopathy, you do give branch chain amino acids, what we call it as a LOLA. That's the L-ornithine, L-aspartate. A lot of studies and a lot of usage has been done showing some amount of improvement from hepatic encephalopathy. So in such conditions we can use, not for others. For hepatic encephalopathy we can use. But then you have to use the other things that is very important, like you have to give the lactulose and the bowel wash and the rifaxiamine, only then you can give. 1 gram per liter. For every liter you'll have to give 1 gram. Replacement is 1 gram per liter. So if you are removing 5 liters, so at least 6 grams of albumin to be given.
Sir, I guess that's all were the doubts.
Okay, fine.
It was indeed a very comprehensive clinical class, sir. We could gather a lot of points from the session. Thank you so much, sir, for your time and the wonderful explanation and discussion. We need your blessings and guidance always. Thank you so much, sir.
Thank you. Fine.
It was a great presentation by Mr. Melvin. We could learn a lot from your well-prepared presentation. Thank you.
Thank you. Thank you, sir.
Thank you, Melvin.
I thank all the attendees for their active participation and thank you one and all. Thank you, sir.